My name is Kristen Kulasas. I'm an endocrinologist at UCSD, and I'm just going to talk about kind of the medical aspect of treating hypothyroidism in the setting of infertility. So as these lovely ladies have expressed, the symptoms of hypothyroidism is typically low metabolism, okay? You're feeling very tired, you're feeling very sluggish, gaining weight, dry skin, constipation, feeling very cold all the time, and then that comes with some menstrual irregularities, most commonly infrequent and heavy periods. How does that affect pregnancy? Obviously, if you're having infrequent periods, you're unlikely to be ovulating. Okay, so you have problems with ovulation disturbance, which is going to affect your fertility. And then once you do get pregnant, okay, we have problems with miscarriages early, and then you can have problems further along if hypothyroidism continues, including preeclampsia, preterm labor, and then the IQ issues down the road. So as far as hypothyroidism goes, what's the prevalence out there of hypothyroidism and infertility? It's actually very hard to capture those numbers. Again, if you're looking at infertility clinics and looking at the prevalence of hypothyroidism there, a lot of the overt hypothyroidism is actually already caught before a patient goes to a fertility clinic. So those numbers can be underestimate. Right now it's typically about 2 to 3%, which is consistent with the general population. Subclinical hypothyroidism, okay, there's lots of studies out there, and the prevalence there is like anywhere from 0.9 to 11%, depending on how you define subclinical hypothyroidism. And then if you're dealing with the euthyroid, normal thyroid function but positive antibodies, again, that's very difficult to capture with these studies. I think I've seen numbers anywhere from 5 to 15%, okay? And you can have positive antibodies in the normal population with no fertility issues, no thyroid issues, and up to 10% of the population. So there is plenty of studies out there showing higher prevalence of antibodies in patients with infertility. So that is quite a topic these days. So how do we define these from a medical standpoint? Again, overt hypothyroidism is a high TSH, a low T4, okay? Subclinical hypothyroidism is going to be a slightly elevated TSH with a normal T4, T3. And then you've got the euthyroid with the positive antibodies. That's going to be a normal TSH, normal T4, normal T3, but your positive TPO antibodies. Okay, so those are kind of how we break it down. How do we define these numbers? As Lauren was talking about, okay, what is a normal range for TSH? Okay, and really, it all depends on the lab. Typically, they have your upper limit of normal being 4.5 to 5. There's a lot of controversy out there. Is that really normal? Do we want it less than 3, et cetera, et cetera? So if you look at normal thyroid function during pregnancy, okay, during your first trimester, your TSH decreases, okay, because of your HCG. So a normal TSH in your first trimester of pregnancy is less than 2.5, okay? Your total T4 is going to increase because of your increased TVG, okay? And your free T4 is questionable, just because the assay is really dependent on albumin, and pregnancy is a low albumin state, so that test might not be as accurate. But your total T4 is going to increase in relation to your TVG, okay? So if we have the normal non-pregnant lab value upper limit being 4.5 to 5, and you have your normal pregnancy upper limit normal being 2.5, really the goal we're looking for typically is a less than a 2.5 for pre-pregnancy. Okay, if we have a patient who's got overt hypothyroidism prior to conception, we really try to get their TSH below 2.5, closer to 1, before they conceive. Because a lot of the problems really you have to catch and keep them euthyroid during that first trimester to prevent a lot of the long-term problems, the early miscarriages, and a lot of the IQ stuff. Okay, so typically if we have somebody with overt hypothyroidism, we tell them to take 2 extra pills, okay, that prior to conception, so increase their dose by about 30%, increase by 2 pills in the first week, with our goal TSH less than 2.5, closer to 1 prior to conception, okay? Now, that's for patients with known hypothyroidism. Do we screen for subclinical hypothyroidism in the general population, or even screen for euthyroid positive antibodies in the general population? The studies out there do not support general screening, but again, when you're in the infertility workup, okay, it's a very easy test, a very simple treatment, that is encouraged to check that TSH and address the problem, okay, if you're struggling with infertility. So by the time a patient gets to an infertility clinic, hopefully they have had at least a TSH, and then if you're having trouble with the normal workup of infertility, we can go further to the antibody testing. So typically, our treatment is levothyroxine, okay? Whether it be a synthetic form, natural form, you need some thyroid hormone, okay? And it's all about that TSH. We really want to make that brain happy, okay? So first trimester, our goal is a TSH less than 2.5. Second and third trimesters, we really want to keep that TSH less than 3. So checking it monthly and keeping that thyroid hormone level where we want it for mom's sake and for baby's sake. Okay? So there was an algorithm I was going to show you that's been published, I think, last year, which was pretty good, and it's all about infertility and thyroid. And basically, if you have a patient with a high TSH and a low free T4, go ahead and treat them, okay, with your goal TSH being less than 2.5. If you have somebody with infertility issues and a TSH in that 2.5 or higher range, but a normal T4, you can still go ahead and start some low-dose levothyroxine as well. And then if you're dealing with the multiple miscarriages or infertility despite a negative thorough workup, you've got normal TSH, normal T4, but you've got these positive antibodies you don't know what to do with. It doesn't hurt, okay, really, to give them a touch of thyroid hormone and see if you can get them to conceive. Okay? All right, that's it. Thank you.